Welcome back. We're here this morning with Dr. Matthew Berger, a local psychiatrist, talking about issues concerning chronic pain and the treatment for chronic pain. Doctor, I do want to pick up right where we left off. You were talking about different types of pain and how those can affect people and affect their lifestyles.
Absolutely. I mean, pain is perceived. Everyone has a different, what we call pain tolerance. Some people have very high pain tolerance, very people have a lower pain tolerance, and it's very individual. However, it's really pretty physiological because pain is perceived through a variety of different mechanisms in the body. The two I'd like to talk about right now, because I think they're most pertinent to our subject, are the serotonin norepinephrine system that is what's called afferent, which means going up the spine. And then there's also a descending or efferent system that comes down the spine. What happens is when you get a receptor, for instance, we're sitting for a period of time. After a period of time, that receptor registers pain. It sends a signal up the spine telling you that you're in pain. What the body normally does, if it's a pain that is relatively minor and that we want to kind of ignore, it will send signals back down the spine through the use of norepinephrine and serotonin to essentially suppress peripheral pain. To say, don't worry about this pain, don't even really feel it. Otherwise, we couldn't sit for as long as we could. We couldn't, hold a skillet for as long as we could. Any number of things that allow us to sort of control minor pain. One of the things that happens is if you have a chronic pain, and there was a very good study where what they did is they took a pepper compound.
Is this the cayenne pepper?
Like a cayenne pepper, okay. A noxious pepper compound. And they put it subdural, under the skin, and what they did is they just let it sit there. Now, it was not debilitating. It wasn't a horrible racking pain, but it was it's almost like a nagging toothache kind of pain. And what they looked at is, did that patient after a time become depressed? And what they found that the patient did become depressed after a time for several reasons. Number one, it's just a nagging pain. If you are in constant nagging pain that unfortunately has no way of being relieved, you can't rub it, you can't push on it, you can't make it go away. After a while, that on a psychological level will cause you to get depressed.
And it doesn't have to be pain that is so severe as they say that it might need you to go to an emergency room or something like that.
No, it can be relatively minor, but it's constant. Mm-hmm. Think of the last time you had sort of a minor, not the type of toothache that required root canal, but just a minor toothache. But it was a weekend, and you couldn't get to a dentist, and perhaps you didn't have access to aspirin or whatever to give you pain relief. It wears you down in a very short period of time. The other thing that happens is, initially, your body will send out that signal, I'm in chronic pain, and it will give you that release of norepinephrine or serotonin. After a while, that becomes depleted. Essentially, the resources that we have available become depleted, and there's not a whole lot more serotonin or norepinephrine to go down that pathway and suppress that pain. Well, serotonin and norepinephrine also play a role in depression. When you deplete serotonin and norepinephrine, you start to get depression. So one of the things that we feel is that that depletion of serotonin and norepinephrine caused by that afferent, signaling process will actually lower the amount of serotonin and norepinephrine to keep you happy.
So it's kind of the proverbial double whammy. Not only is the serotonin and norepinephrine being used to suppress pain, but it's also being used to regulate your mood, so to speak. And so therefore, when you deplete it, you're not only not relieving the pain, but you're also creating the depressive or anxiety situation.
Absolutely, and to even get more complicated.
I was hoping not to get more complicated.
That's the easy part. There is a process where inflammation, which occurs whenever you're in pain, because you get inflamed, etc., releases a series of catecholamines in the brain, which then release pro-inflammatory factors, which actually cause a downregulation of norepinephrine and serotonin, which then cause a cascade, which causes a decrease in something called BDNF, brain density neurotrophic factor. And I know we're getting pretty complicated here, but essentially will actually shrink sections of the brain.
Wow. So how do you then go about taking care of something like this?
I mean, first of all, again, multiple levels. The first level is from a psychological level, getting the patient to come to terms with the changes in lifestyle. Perhaps this guy is never going to go become a bowler again. He was a big bowler, loved to bowl. Well, he has this injury, he can't bowl anymore. So now we have to take him away from whatever he liked to do and kind of slowly have him come to terms with, okay, I'm never going to be a bowler again, but I can do other things. And get him to shift his interests to something else that he can do. Maybe he can work a computer. Maybe he can play ping pong. I mean, I'm just saying. So the first thing is to come to an acceptance, because the more you rant and rave and worry about the things you can't do, it holds you stuck from moving to things that you can do and maybe change. Obviously, I picked something innocuous by bowling, but work is obviously even more important.
Or like I deal with, work or other lifestyle things that people are used to doing, even if it's simply working around the house. That
Absolutely.
You can't work around the house anymore.
I mean, a number of people who, you know, women or men who cannot do the tasks that they used to do at work. And one of the things I often hear is it makes me crazy to have to pay someone to do something I used to be able to do, and especially for men, should be able to do. Now, we always try to work around those shoulds because, you know, well, you should, what does that mean? You know, I can't change a light bulb. I should be able to do it. I can't. So to get them to come to acceptance that those things that they should be able to do, they can't do anymore. I think that plays a big role, the acceptance. And then the next thing, of course, is medications. We have a lot of medications that are very effective in treating that norepinephrine serotonin deficiencies that it can occur with pain and depression.
And one of the things that I experience and some of the difficulties that sometimes my clients have are there are occasions when you're prescribing medications that haven't been traditionally approved, if you will, for treatment of chronic pain or chronic pain-like symptoms.
A lot of the medications we use are what are called off-label, exactly what you said, because there is no benefit for the pharmaceutical company to spend millions and millions of dollars to get it approved. And yet there's a tremendous amount of both anecdotal literature and clinical experience to say these things work. They also work from a point of view of the theoretical. Why would they work? Well, they work on norepinephrine and serotonin. The two drugs that we do like to look at, one is very, very old, Elavil, amitriptyline.
I was going to mention that, yes.
One of the first antidepressants ever on the market is a norepinephrine serotonin drug and has been used in chronic pain for probably 50 years. Used for chronic headache, used for peripheral neuropathy. The problem with the older drugs is that they have a wealth of side effects: dry mouth, constipation, orthostatic hypotension, sedation, and a variety of more dangerous side effects, heart disease, heart conditions in some case. The newer drugs, which are also SNRIs, the two that come to mind most frequently are Cymbalta and Pristiq, which are the brand names, are also serotonin norepinephrine drugs, but have almost no side effects. Sometimes a little bit of gastrointestinal effects. The difference is a couple of things. Is number one, it's not like taking a Vicodin. It doesn't work 2 hours later. These meds take 4, 6, even 8 weeks to kick in.
Okay.
And I like to call them background drugs. They're kind of constantly working in the background to, again, suppress that pain. But it's not like taking a Vicodin or a morphine or a fentanyl patch where you're going to feel something immediately.
And I've heard doctors and sometimes even some of my clients tell me that they try to get these medications into the system, and so that it takes a while for it to get into the system and start to provide that long-term constant relief.
Right, and I think you have to think in terms of months, not weeks. A minimum trial, and this is a key, minimum trial is 6 weeks. A true trial is 3 months. And oftentimes we have to adjust dosages. You know, sometimes the first dose isn't the dose that works.
Doctor, we have to take a break right now. When we come back, we're going to pick up with Dr. Berger discussing the use of various medications, both on-label and off-label. When we return on You Be the Judge. Welcome back. Doctor, let's pick up because we kind of broke that sort of in the middle of a train of thought, and I apologize for that. But we were talking about the use of medications, some that we've known are used in the treatment of depression, and others that, as you were saying, have become useful in the treatment of chronic pain.
Yeah, as I was saying, you know, it's important with these drugs to give it time. You know, there's an old expression in medicine that time in and of itself is a drug. And I think a lot of times when you're in pain, it's hard to be patient, and you want, especially if you've come from the treatment with things like the opiates or some of the non-steroidals, where you do get relief essentially immediately, to be able to say, okay, this is going to take 3 or 4 months. As I was saying before, a lot of times dosages have to be adjusted, increases in dosage, augmentation with other drugs. So really it's a 3 or 4 month thing, and again, it is a background drug. It's not like taking a fentanyl patch or something that's going to give you immediate relief.
You bring up a good point, something I did want to discuss if we could, and that is, do you find yourself dealing sort of interdisciplinary, if you will, like you, from the psychiatric standpoint, along with, say, physical medicine or orthopedic surgery or even neurosurgery?
Yeah, absolutely, all the time. I mean, one of the things we often find is that the other doctors will have prescribed other medications, which is not uncommon. Especially, we have to be careful with addicting substances, and there is a real danger of patients becoming addicted to opiates after they've had chronic pain. And opiates in and of themselves can be depressogenic. They can cause depression. And sometimes you can get rebound pain, where you've gotten so used to the use of opiates that when you start to have them wear off, you actually get rebound pain where it spikes above. Well, this is where some of the ancillary medications, like the antidepressants, also things like Depakote, which are used for seizure medications, Tegretol, Neurontin, which are all off-label. Let me clarify that. They're not indicated for pain, but again, they're used for the expression of pain running up and down the nerve ending, because that's where they work. They work on the nerves to control the receptors so that you don't get that expression of pain.
I don't want to leave people necessarily hopeless in this situation, because that's the purpose of our conversation here this morning. Is there what I'll call light at the end of the tunnel for people who are treating for chronic pain?
I think there is and there isn't. I'm not going to lie to you. Very often it is very difficult to treat chronic pain and its concomitant depression and mood disorder. Patients with chronic pain when they become depressed, are irritable, they're short-tempered. In many cases, it affects their interpersonal relationships with their families, because now this real easygoing guy or girl is constantly in pain. Well, think of the last time you had that chronic toothache. You weren't a whole lot of fun to be around. Well, add that times 5 years. So it affects all spheres. It affects your work, your home life, your interpersonal relationships. I think what I like to say is, with patients who have chronic pain, I can usually get the depression under about 70% control. I usually can't get it under 100% control.
A lot of the people who are watching here obviously don't suffer from chronic pain, thankfully. What I'm wondering now is, are there things that they can look for in loved ones or people that they're living with that might help direct that person to seek, say, for instance, treatment with a specialty like your own or another one of the specialties?
I mean, change in personality. That's a big one. You know, like we said, somebody who was easygoing, jovial, easy to get along with, now is irritable, short-tempered. Isolation. I don't want to leave the house. I don't want to be around my friends and family. Something called anhedonia, which is a big way of saying I don't enjoy things I used to enjoy. So again, this is a person who maybe used to love to go to the movies. Now, he could still go to a movie because he's not physically impaired, but he just doesn't want to. That's the depression. Changes in sleep and appetite. Changes in motor function, you know, where they just want to sit on the couch, they don't want to do anything. Changes in energy level. And one thing that's undernoted, changes in focus and concentration. Lots of times patients who have depression and comorbid chronic pain will say that they feel foggy. And the knee-jerk reaction is to think it's the morphine or whatever pain med they're on, which can do that. But a lot of times it's the depression in and of itself.
So the bottom line on that is if you start to see these things, it might be beneficial to suggest maybe seeking the services of a different type of a specialty.
Right, because a lot of time the physical medicine doctors, the guys who do the orthopedics, and even some of the chronic pain doctors, so I'll have to say most chronic pain, like neurologists or rheumatologists who treat a lot of chronic pain, are pretty aware to look for that, but sometimes they're not.
One of the things you and I talked about in our last show, and I'm sure many of the people who are watching don't remember that, but we talked about traumatic brain injury and traumatic brain injury symptomatology. Do you see any meshing of those symptomatologies with chronic pain?
We do, because a lot of times chronic pain is caused by head injury, auto accidents, falls, a variety of different sort of traumatic events. And unfortunately, a lot of times they will have what are called traumatic brain injuries, which don't show up on a CAT scan, don't show up on an MRI. And oftentimes we'll see, again, the mood swings, the irritability, the cognitive impairment, short-term and intermediate memory. I've had patients say to me, I used to be able to do math in my head, but since I had that fall, even though I didn't lose consciousness for a very long few seconds, now I can't do higher math in my head. So we see a lot of traumatic brain injuries. One of the things that we can expect to see, unfortunately, coming back from the different wars that we're involved in right now, is the government expects that there'll be over 161,000 people who will come back with traumatic brain injuries.
From what?
Well, unfortunately or fortunately, our current body armor really is protecting our soldiers in a good way from serious bodily injury. But what's happening is they're getting a series of concussive blasts where they're getting sort of, for lack of a better word, getting their bell rung over and over again like a football player might or a boxer, which leads to these post-concussive injuries. Their head is safe inside the helmet, but unfortunately the brain is rattling around inside the skull. And oftentimes they'll be in 20, 30, 40 of these concussive blasts, whether it be from artillery, an IED, or any number of things. The cumulative effects of those multiple concussive blasts and concussions will lead to traumatic brain injury, which can often lead to these changes we've talked about.
And are you seeing that with regard to some of the people that you're involved with?
Absolutely. I do a lot of work with the vets. I do a lot of work with post-traumatic stress disorder, and we're starting to see a real uptick in the number of TBIs, traumatic brain injuries. Unfortunately, it is oftentimes not picked up until much later because it's not a gross pathology. You don't see it like the patient isn't drooling on himself and can't remember his name. It's oftentimes very subtle.
We're going to take our last break right now. When we come back, we're going to finish up with Dr. Berger in discussing issues concerning chronic pain, as well as a little more on his involvement with veterans and post-concussion syndrome when we return on You Be the Judge. Doctor, let's pick up right away where we left off because we're in our last segment here, and that is we were talking about your involvement with veterans coming back from some of the wars and some of the military police situations that we find ourselves around the globe. What are you seeing in terms of your ability to assess those conditions right from the get-go?
Well, I think the armed forces are trying to do a much better job of assessing for post-traumatic stress disorder and TBI almost immediately. There are still a lot of barriers, one of which is the stigmata involved, especially with active duty guys who don't want to talk about it because unfortunately if you get labeled with TBI or PTSD, you're oftentimes not going to be able to go back into combat and you're not be able to get the promotion. So they do tend to cover it. The other thing is a lot of times when they're being mustered out, they don't want to deal with anything. They just want their DD2 and get out and move on. So a lot of times it's sort of a lick and a promise, the screening tools that should be done.
Now let me ask, we talked specifically when we were talking about chronic pain about other people being able to observe and what they should observe. Are you finding that to be the same type of a scenario with regard to these soldiers and the TBI and post-concussive syndrome?
Yeah, absolutely. I think it's oftentimes the loved ones who see it rather than, unfortunately, the patient themselves. A wife, a mother, a brother, a sister who goes, you know, my significant other, whatever, is just not the same person as when they left.
Now, besides the treatment that you provide to the veterans, I know you provide some other helpful services to the veterans.
Well, we do a lot of evaluations for vets, and we've worked with them for a while, but one thing that's very near and dear to my heart is I've worked with an agency called anysoldier.com, and up to this point we've sent over 3,000 care packages, for lack of a better word, to soldiers in Afghanistan and Iraq. We've had a series of fundraisers and collections. I pay all the shipping myself out of pocket, and there's no cost. We've had some great response from things like nursing homes, Cub Scouts, church groups and organizations, hospitals locally. And
coincidentally enough, we have another event coming up.
Yes, we do. Coincidentally enough, not this coming Sunday, but the following Friday, which I believe is the 25th, we're going to have an event at Burton Irby's in Wilkesboro. Where we're going to be having, I'm going to do some celebrity bartending, and we'll have some other people there as well. my partner, Dr. DeSoto, where we're going to be collecting certain items, which we'd like you to donate. I will ship over there. We're actually having a little push for Easter. We're going to send a whole bunch of Peeps over and a few other comfort items. So if there's any way you can get out, I'd really appreciate it.
And those items are up on the screen right now as part of the little brochure that you're handing out with regard to this.
Right, thank you. I appreciate the opportunity for you. I mean, it's a really wonderful cause. And you know what's amazing to me is we get a ton of return letters from these people who are busy, you know, in the combat saying thank you, which is unnecessary.
Thank you, by the way, for coming in today, and thank you for what you do with our veterans. And thank you, our viewers, for tuning in today to watch our show about chronic pain and a little bit about the doctor services to the veterans. See you next week on You Be the Judge.